Well, great to see both of you. Thanks so much for making time for this conversation. Wondering if we could maybe just get started with some introductions. Would love to hear who you are and where you work and what your day-to-day is like and how you found yourself in the field. So I don't know, Dr. Cruz, maybe do you want to get us started?
Sure, and thanks, Kevin, for this invitation to join you today. So I'm Deidra Cruz. I'm a professor of medicine and a kidney physician or nephrologist at Johns Hopkins. And I got interested in working in kidney disease, I think for a couple of reasons. One, I come from a family that has been affected by kidney disease, including my favorite aunt that my daughter is named after. I also, early in medical school, really found the kidney to be quite fascinating. And so when it was time to choose a career, I was excited to choose kidney diseases and specifically nephrology. And I spend most of my day job doing a combination of things, spending most of my time conducting research to try to address disparities that we see in kidney disease, and also doing clinical care, as well as training the next generation of people that will hopefully do the same.
Thanks. Dr. Purnell?
So hi, and again, I also say thank you to you, Kevin, for having us here. I am Tanjala Purnell. I am an assistant professor, excuse me, of epidemiology here at Johns Hopkins University. I have joint appointments in the departments of surgery, health policy and management, and health behavior and society, in part because I also teach in different departments here. So I am trained, obviously, as an epidemiologist, but also as a health services researcher. I, focus on health equity research. I focus on wanting to tackle health disparities, most specifically in chronic diseases. I got into this particular field as a first-year PhD student who was introduced to the field of chronic kidney disease and transplant and started to learn about the stark disparities in this field. And they reminded me a lot of why I wanted to get into the field of public health in general. So I'm from the state of Mississippi, where, as you may know, we have a very high burden of chronic illness and disease, and in particular, health disparities. And so I was really attracted to the field of public health because I wanted to tackle health disparities. My day to day looks like very similar to Dr. Cruz, minus the clinical work. So I do a lot related to research. So I have a research team here. We focus on using large data sets to help to identify factors that may be driving disparities, but then we also partner with patients, with community members, with faith leaders, in trying to develop programs to address disparities. And I also lead several educational programs here at Hopkins, where we also try to train the next generation of health equity researchers. So that's what I do.
Thank you so much. And hearing both of you describe your day-to-day makes me feel that much more amazed that we found an hour that worked for all three of us to talk. So grateful for your expertise that you're bringing to this conversation. And just to sort of frame for viewers, we're talking, at the almost the last week of 2020, a year where there's obviously been increased attention on sort of public healthcare system, or the healthcare system more broadly in the United States. Also a year where there's increased attention on racial injustice, racial inequity, and violence against Black Americans. And wondering if you two might want to talk a little bit about your work specifically through that lens, where racial disparities in the healthcare system just intersect with ongoing structural racism in society.
Sure, I'm happy to start off. This year has really been trying, I think, in a lot of ways. One of the things that gives me some hope, though, is that this attention that has been necessarily paid to these issues that you raise, these issues of racial injustice, as well as all of the health disparities that have really come to the fore in the setting of the COVID-19 pandemic, I think has given new attention to these topics that many of us who've been working in this area for a very long time have always hoped that these areas would get this sort of attention. And so in my optimistic moments, I think about that this is an opportunity, I think, for us to move some of the work forward that we had been hoping to move forward for quite a long time.
Yes.
And so, yeah, so Dr. Purnell, I don't know if you want to comment as well.
Yeah, it's gonna just completely echo, what you said. You and I have known this for a long time. This is probably why many of us have gotten into this field in general. We've been trying to sound the alarm for a very long time. And, Dr. Cruz is very optimistic by nature. I try to be, but there are days when I know that she and I and others, this weighs on us as well, especially when the conversations are not focused on the what do we need to do about it now. If the conversation focuses on the, oh, come and just tell me about this problem that, oh, we had no idea that health disparities existed. Just come and talk about it, but I don't want to commit to doing anything about it. I think that weighs on us very heavily now more than ever, because this is not just an academic exercise. Like, we are also watching members of our own families, members of our own communities pass away as we are struggling to not only sound the alarm, but also to help lead new initiatives to really tackle these disparities. And so it's very personal to us as well as professional. And in that sense, it also at times takes an emotional toll on us as well.
Well, I appreciate that. And I hope that we can spend maybe the second half of our conversation, Dr. Purnell, doing exactly what you just said, of talking about what do we do about it now. And maybe to set the stage for the conversation, Dr. Cruz, I'm going to read this because I want to make sure that I get the stats right. From this ProPublica article that I think was just published last week, in which both of you were quoted. Chronic kidney disease affects people of all races at similar rates, but Black Americans are 3 to 4 times more likely than white Americans to reach kidney failure. So, Dr. Cruz, I'm wondering if you can just walk us through a little bit of like the where and the how and the why inequality shows up related to kidney disease.
Sure, that's a broad question, an important question. I'll try to succinctly, I think, walk you through it. I think when we think about the whole continuum, if you will, of chronic kidney disease, where we think of people who may have risk factors for developing it, and then we think of who then among that subset will go on to see their disease progress on to developing kidney failure, what we see are just profound inequities across that full continuum. And so the ProPublica article highlighted that when we look at early chronic kidney disease, we actually do see fairly similar rates of who is affected by that when we compare Black Americans to white Americans, for example. When we, though, focus then on who sees that disease progress, meaning on to a need for either transplantation or a need for kidney dialysis, that's when we really see these disparities quite evident between these two race and ethnic groups. And so some of the factors that are at play there are that there are disparities even in the detection of kidney disease. So meaning that a physician or other healthcare provider has done the proper testing to be able to diagnose a person with chronic kidney disease. That includes both blood and urine testing. We know that there are disparities in the receipt of those. And then the communication that needs to happen after the testing has actually been done is not uniformly happening when we look by racial groups especially. And then from there, access to specialty care, access to a physician like myself, a nephrologist, who can then provide both education but also preparation to those individuals as far as what they might expect if indeed their disease is progressing and they're going to need a transplant or going to need to start dialysis. There are disparities in access to see a nephrologist. And then certainly when we move towards those people who do develop kidney failure or close to developing kidney failure, when we then think of getting them access to the optimal therapy for kidney failure, which is transplantation. And I know that is something of great interest to NKDO, and would certainly want to invite Dr. Purnell to comment since she's done so much work in helping us to understand disparities in transplantation.
Absolutely. And so, just sort of continuing where Dr. Cruz left off, we know that unfortunately, so, as she mentioned, in the earlier stages of chronic kidney disease, we have, pretty similar rates. But by the time you start to look at the numbers in terms of complete kidney failure, that's where we really see, the just tremendous disparities among, our Black Americans, Hispanic, also American Indian, Alaska Natives, almost pretty much everyone as compared to non-Hispanic whites. But when we, really focus on the why, right? It's really looking at what are the two leading risk factors. We know that they are diabetes and hypertension. And so many of these same issues in terms of why do we have uncontrolled diabetes? Why do we have uncontrolled hypertension? So a lot of those same social determinants of health, issues related to access to care, et cetera. But now once we, have a population of people who now are dependent upon the science and the technology to stay alive, so meaning either chronic dialysis treatment or transplant, what we often see is that certain groups, in particular, we know Black Americans in some areas are only presented dialysis as a treatment option. Some of them, quote, crash onto dialysis, meaning they had no idea that their kidneys were shutting down. And by the time, people present to the ER, it's pretty much, we have to immediately start you on dialysis. But even those who were in care and had, some indication that they were progressing towards, end stage kidney disease or kidney failure, often we don't have those same timely conversations with physicians. Often, we see that referrals to kidney specialists, such as Dr. Cruz, come much later in the process, meaning that patients may not have time to first fully grasp that this is happening. When we think about, for example, a 35-year-old Black man who thought that he was healthy and all of a sudden is being told that not only is he not healthy, but now he has to be on dialysis for the rest of his life and, just trying to cope with what that means. We have to think about what, those conversations might be like. We have to think about the fact that we know that there are perceptions of what certain groups of patients will or won't be interested in. So we know that unfortunately, there are still some people who believe, well, for example, Black people don't donate, or Black people, don't want to pursue a transplant. And so the nature of that communication is very different from a patient that you think would truly be interested in it. So all of these things, so thinking about timely access to care, thinking about, discussions and timely referral for specialty care, or even referral to a transplant center, but then, which we can talk about later, all of the barriers that happen even once we get people to the door of a transplant center. So that's not the end of the story. So, but I'll stop there, for now, and just saying it's a lot to unpack, Kevin. It's a lot.
Do you want to keep going a little bit about the transplant center specifically, Dr. Purnell?
Sure, I can do that.
Yeah.
So we'll continue going, right?
Sure.
So, once we get through those initial barriers of getting people referred, getting people interested, getting people, educated about the treatment option, or even getting to the door, we know that you don't just show up at a transplant center and automatically get on the waiting list. There is a clinical evaluation process that often, in some places takes weeks to months, sometimes longer than a year to complete. There are several different tests, some that are considered routine tests, and that, really could vary based upon the quality of primary care now that patients have, and just the whether or not it's easy for them to access those results. There are often breakdowns in communication. We now know that there are many times where transplant coordinators may think that, they're waiting on something from the patients, while the patients are thinking that they're waiting to hear back from the coordinators. We know that even just trying to think about things like taking off of work to show up, for scheduled appointments, the type of job that you have could really make a difference. For example, whether you're salaried or hourly, and that could, also play a role in the team's perceptions of whether or not you're committed to this. If you're not showing up to appointments because you are afraid that you might lose your job. But if people don't understand that, all of these things could be barriers sometimes having to travel a great distance to go back and forth to the center. Some people may travel for 90 miles or longer. Things like childcare, things like, even which you may appreciate, we haven't really brought into the conversation the idea of a potential living donor. And so, we all know that the big elephant in the room is that even once, patients make it to the waiting list, we still have a wait time because we have a shortage of organs. And so, we're all promoting living donation, but we all know that not all patients are created equally in terms of their access to people either in their families or other close social networks who are healthy enough to donate. But that is a separate evaluation process as well, right? And so we have these two things going on at the same time where we can lose people at multiple stages of this evaluation process. But all of that at the end of the day just ends up looking like ones and zeros, right? Like, did you complete the process or not? And that whole, did you complete the process? Often, I think, some projections at some transplant centers are as high as, 80% of the people who start the transplant evaluation process never make it to the end. And we know that that disproportionately impacts the same communities who are less likely to get a transplant in general.
Yeah, if I could add to that, so as someone who I treat people who are on dialysis, who are treated with dialysis and are also in many cases waiting for a transplant. Maybe they were not fortunate enough to get preemptively, as we refer to it, listed for a kidney transplant prior to having a need to start dialysis. And so they had to go on and start a dialysis kind of regimen and have then tried to pursue the process of being listed. There are disparities there for sure as well for this group. And so much so that there was a fairly recent policy change to try to basically give those types of patients some extra points, if you will, on the waiting list, because these disparities were so apparent as far as what would happen for people who, again, had to start dialysis and then pursue transplantation a little bit later than others. And then unfortunately, what we see is many of those people die waiting, particularly those individuals who already, again, have had to initiate dialysis. And so, and as Dr. Purnell mentioned, the number of steps that a person has to go through in order to get listed for a transplant are just, for many people, really daunting, especially when we layer upon that challenges that they may be facing just in general from whether it's navigating basic kind of social needs that they may have. We, during this pandemic, have seen issues such as food insecurity highlighted, housing insecurity highlighted as well. Unfortunately, these two challenges disproportionately affect Black Americans due to long-standing structural racism in this country. And so then when we look in the space of transplantation, and we're wondering, well, why is it so hard for people to just make sure they're getting their appointments taken care of? And, why are we having issues with return phone calls and the like? All of these other challenges that people are dealing with come into play when we think about how people are able to then move through the process of being listed. And then when it comes to the actual donors, that we certainly, when we think about transplantation, again, the optimal treatment for kidney failure is for sure transplantation, and the most optimal is to get that kidney from a living donor. Those kidneys work faster and work longer than people who receive a kidney from a deceased donor. We know that through many studies, but there are so many barriers as well to individuals donating kidneys. And there's a lot of, I think, mythology out there about when it comes to certain racial and ethnic groups having sort of cultural reasons for not donating. Those are really less of a factor than there are real structural issues, socioeconomic factors. There was a really elegant study done a few years ago showing that when we actually compare, for example, Black Americans And white Americans, when we compare them by their income level, but actually Black Americans are more likely to donate if matched, when we match them to white Americans at the same income. But the issue is that, again, Black Americans are disproportionately among our lower income sort of sect of the population, and those economic barriers are the real things that many of us believe in, and certainly through Dr. Purnell's work documented, seem to be the bigger drivers of kidney donation. And it would behoove us, I think, as a population, and particularly for those of us engaged in advocating for certain policies around this, to really think about removing those types of barriers if we want to move forward equity when it comes to living kidney donation.
So the two things I want to lift out, I really appreciate this. Two things I want to lift out. One is that at this every step of this multi-step process, that it's not that there's one point where we see racial inequity show up. Like at every step, we've got to be thinking about where, and tell me if I've got this wrong from my notes, but we've got to be thinking at every step of like where and how racial inequity is operating. And then the other thing that I'm sort of jotting down as we go is that if we think about this in a silo, we miss the bigger piece and the bigger picture of where structural racism in the United States comes into play, and thinking about if we're just talking about kidney disease and not also talking about access to housing or food insecurity, then we're missing the full context that we really need to address if we're going to think about how we move forward. Is that mostly right? Is that close to right?
Yes, you got it, Kevin. You got it. We are ready to welcome you right on over to our ranks, right? You're ready to jump right in. That is exactly right. And that's what all of our talks now say to people. It's not just kidney disease. It's not just diabetes. It's not just hypertension. It's not just any one thing, just like it's not just any one barrier. For a very long time, for example, much of what NIH was funding were just programs to educate patients about transplant being a beneficial treatment, right? It was sort of like, if we just get them to the door, the disparity will be over, in a sense. Not, that's a very simplistic view, but you get what I'm saying. Like, so much of the funding disproportionately focused on just the education piece. And what we now know is that you can be the most educated person in the world. We actually see in some cases disparities that are greater at the higher income levels and higher education levels than they are at the lower ones. In certain outcomes and access to care measures at the very at the poorest neighborhood levels, we often see, okay, everybody's just doing bad, in some conditions, whereas we still see those very stark disparities by race and the very high income levels. That lets us know, that has always let us know, that this is something else going on. And not saying that this is in any way an indicator that a group of people were born genetically inferior to another group of people. That is ridiculous. And I'm going to just call it ridiculous very plainly, because I want us to move away from that narrative. What it says is that there are other factors and other experiences that this group of people who have been labeled as Black or African American or whatever other, creative label was given at the time, have experienced in this society for a very long time. Experiences of discrimination, experiences of racism, experiences of neighborhood segregation in ways that then influence, for example, the quality of public education, the quality of housing, the exposure to environmental toxins. We know that everything all, lends itself back to a policy angle. And all of this, is sort of rooted in these structures and these systems that then, lead us to sort of why we see stark disparities in kidney disease, why we see stark disparities in everything. And I think even, now more than ever, we can say the same thing with COVID-19. If this was something novel to all of us, and we had no real reason to believe that any one group should be genetically predisposed to having worse outcomes, then that lets us know it's something that we are doing wrong as a society when we see that the exact same groups who have worse outcomes in everything else, also now all of a sudden also having the worst outcomes with new conditions and new diseases, you know, that pop up. So I think that you're exactly right. And that's exactly, you know, if the audience leaves with nothing else, is that none of this operates in a silo. All of these things are related to each other.
Well, I want to make sure that we don't just leave with that, because earlier you helpfully pushed us in this direction of thinking about, okay, so what do we do now that we have this information? So I'm going to ask, I think maybe like a big question with a couple threads and let you two pick up whatever feels most relevant. But I guess maybe two things I'm thinking. One is, are there bright spots, either transplant centers or geographies or places where we're starting to see of like progress on closing this racial health gap? And then the other thing that I'm wondering about is just in terms of operationalizing this. Like from what I understand about your research, there's some work to do within the medical community. There's also some policy change work to do. And I'm wondering specifically for people who think about encouraging others to become kidney donors, like what are the things that they should be thinking about and that we should be thinking about at NKDO that are helpful in addressing the issues that we've been talking about? I promised you it would be a big question. I tried to live up to it. Dr. Cruz, you want to start?
I'll touch on a few things. So I guess one bright spot is from a policy standpoint, there is legislation that has passed through the House of Representatives that is set to be voted upon by the Senate that focuses on.
Just voted.
They did just
vote
vote
yesterday, right?
Oh, well, you'll have breaking news then. It wasn't approved?
I saw an email overnight. I hope it was right. I think it came from NKF, so.
Okay. I haven't heard. Okay, well, we may have to edit this if there's an update. But there's recent legislation, let's say, that we hope will pass, focused on coverage for immunosuppressant therapy for people who do receive a transplant, to extend that coverage beyond just 3 years after receiving the transplant. I mention this because that piece has been a tremendous barrier for eligibility to be listed for a transplant. Basically, most people have to have, in addition to their Medicare or their Medicaid coverage, they have to have a secondary, usually private insurer to be able to get listed for a transplant, because it's known or has been known to this time that after 3 years of having the transplant, then their coverage for their medications would end from the standpoint of Medicare. So that is one bright spot that many of us are optimistic about. I think some of the other bright spots are in some of the work that's being done around figuring out better ways to actually educate people who have advanced kidney disease about the option of transplantation. There are a number of different clinical trials that have been conducted, and some newer ones that are being conducted around this, including approaches such as patient navigators to help with some of this process as far as going from one step to the next. And there's been some evidence that type of approach is effective at helping people, including racial and ethnic minority patients, to navigate those things. So those are some of the things that I see as being hopeful with respect to the way forward with this issue.
Yeah, now we'll also try to tackle this very large question. So some things that, just pop up off the top of my mind, and I'll try to go at, looking in my brain at this social ecological model. We told you that there were barriers at every level. So I'll try to think about things that I'm aware of at different levels. So locally at, like the center-based level, I know that, we here at Hopkins are doing some work around social media and advocacy. So Dr. Dory Segev and, our group are leading some work related to living donor champions, which is also being rolled out at other centers, including Northwestern and UAB. I know that at Duke University, Dr. Ebony Boulware has been, who was also here at Hopkins, has been doing a lot of work around both patient education, but also system level changes in terms of thinking about getting people into systems of care at an earlier stage in hopes of getting, increased access to transplant and removing some barriers. At Emory, Dr. Kimberly Areola has been doing work around racism and looking at specifically how that, could be targeted as a barrier to transplant for a very long time. Dr. Rachel Patzer's group has been doing some stuff around trying to improve our metrics around referrals from dialysis centers to transplant centers. So, looking at multiple levels for that. Going back to Northwestern, I know that the group there has done some actually tailored education for the Hispanic population that is, so prevalent there. So Dr. Lisa Gordon and her group, but then also now Dr. Danae Simpson is there and has started their first African-American transplant access program, which of course is a very big issue in a city like Chicago. Also here at Hopkins, some of the work that I'm leading is trying to really rally around. So we know that once the community learns about these barriers, once the community learns things like, hey, people receiving long-term dialysis are much more likely to die or to have a lower quality of life, the first question they say is, how can I help? And so what I've been doing is really partnering with, so we've actually had some of our transplant candidates here who participated in focus groups and are moving forward with us on new programs where we are actually bringing in our faith-based leaders and other community organizations who are saying, let's all get together and think about ways that we can, sort of help our community members. And, that's very exciting and very promising. But we're also, again, thinking more upstream about, let's also think about how we can reduce the burden of kidney disease and kidney failure in our community in general. How can we, educate people about what it means to be a living donor? And then how can we also provide better support at every level for those who donated to make sure that they don't become people who then themselves at some point develop risk factors for kidney disease, because we know that that's also important. Our patients want to know that their family members, that their friends will be safe. And so we know that we have to also give the best quality of care, but also just rallying around at a community level to protect our living donors who are doing such a tremendous service to the community, to society, to the greater good.
Well, I feel kind of heartened to hear how many bright spots and studies and experiments you were able to point to of people and places around the country that we should be looking to learn from. So I really appreciate that. I feel especially hopeful about this notion that once people hear about what's happening, the instinct of, so how can I help? It's the thing that we keep seeing. And I know we've covered a lot of ground in this conversation, but I also always want to leave a little bit of room for either of you. If there's anything that we didn't get a chance to talk about that you were hoping that we would, or you feel like we should, floor is yours. Feel free to throw in anything that we didn't cover, and then I'll try to wrap us up a little bit.
Yeah, I would just like to add that I think that NKDO can really help with this effort through helping with getting the word out about how safe donation is and how rewarding it is. I think that helps us. These personal stories really helps for those of us who are either evaluating as clinicians who are evaluating potential living donors. It's something that we definitely try to educate them about, but hearing that from someone who's actually been through it, I think is so beneficial, and it's going to help all of these efforts that we've shared today. So I just want to put that plug in that to please continue to do that work because it's so important.
I love it. And the last thing that I'll add is that I want to remind, our audience members that we all can play a role, and we all are obligated to play a role. Once we learn about all of these barriers, all of these issues, there is not a single human being who cannot bring a skill set or perspective or, a talent or something that's valuable. There's so many different ways that we can help patients, that we can help to protect our donors. And, we welcome that. I welcome that, even with my students, I say, no idea is silly or ridiculous. We we welcome creativity, and we need that. You know, I think that the fact that we still have these long-standing disparities speaks to the fact that, one, this is such a complex issue, but it also is because there are so many different factors that impact so many different fields, which also means that we all can play a role in tackling these really huge issues, and we have to. That's the only way that we will do it. And, you know, these disparities impact all of us. They don't just, I think COVID, better than anything else, has taught us that these disparities don't impact small pockets of people, you know, just like, you know, I'm religious, so the Bible says what we do to the least of these. And so, you know, what happens to any of us impacts all of us. And so we have an obligation and a role to play. And we welcome, you know, all of you to join us in this fight.
Well, I'm so grateful for the roles that each of you play in this fight and for taking the time to sort of walk through these questions and answers with us today. If people who are listening want to find more of your research, I think that we'd point them towards your website. Is that your respective websites? Is that the right spot to go? Where can we find more of your work? Because I think people are going to want to find more of your work.
Yeah, please. You know, our websites, our faculty pages. We're both on Twitter. I'm on Twitter because of Dr. Cruz. So we I think share, you know, we mostly just share, you know, articles that we think are important or other things in the field. So certainly social media, our faculty pages. I know, Dr. Cruz, did I leave out anything?
Yeah, for sure. So, you know, please follow me at Dr. Deidre Cruz on Twitter. You can also follow our Center for Health Equity, which is at JH Health Equity, and also our Center for Health Equity website, which is healthequityhub.com, for information, I think, more broadly speaking about these topics surrounding health equity.
And my Twitter handle is tpurnell1908.
That's great. Well, we'll include those links and notes for people who are watching so they can click and find. And thank you two again so much for your time today and for the work, and looking forward to our paths crossing again down the road.
Awesome. Thank you for having us. And thank you, Kevin, for your important work as well.